Greetings. Welcome to the Robert Wood Johnson Foundation Systems for Action Research Program in our Research in Progress webinar series. Thanks for joining us. We're going to give folks just a few more minutes to get dialed in. I see our participant numbers are climbing rapidly, so hold with us for another minute or so, and then we'll get started. And welcome everybody. You have tuned in to the Robert Wood Johnson Foundation Systems for Action Research Program in our regularly recurring Research in Progress webinar series. Thanks so much for joining us. If you're new to Systems for Action, we are a signature research program of the Robert Wood Johnson Foundation. Our mission is to discover new ways of helping medical, social, and public health systems work better together to improve health and to tackle health inequities across the American communities. We fund studies all over the country, testing and looking at a variety of novel strategies for helping these different sectors work together, helping to align delivery systems and financing systems across medical care, public health, and social services. And we do this webinar a couple times a month. We feature a research team who's doing innovative work in the system alignment space and have a chance to get an early look at what they're learning from their research studies and have some interesting conversations about what these findings mean for improving health and health equity across the country. I'm Glenn Mays. I'm a professor here at the University of Colorado, and I direct the National Program Office for Systems for Action. And I will be serving today as our host and moderator. And really excited to have as our featured speaker today, Dr. Rachel Hogg-Graham from University of Kentucky. Full disclosure, Rachel and I have been research colleagues for a number of years now. And so I have a particularly insider vantage into the work that Rachel and her research team is doing in this space. Rachel has been funded through the Systems for Action Research Program and a collaborator on S4A research. She's also been a very important collaborator and leader with our intramural research team at Systems for Action, making use of the large national longitudinal survey that we conduct through S4A called the National Longitudinal Survey of Public Health Systems. And she'll be sharing with us some of her work. I think some findings from probably a couple of different studies she's working on, looking at system alignment issues. And in addition to having been funded through S4A, she's also had other research projects funded through other units of the Robert Wood Johnson Foundation. And she's also been funded through a Career Development Award from the U.S. Agency for Healthcare Research and Quality, or HRQ, looking at these issues of system alignment across medical and public health systems as well. So I think we're going to hear some interesting findings, work in progress, probably from several different studies that Rachel and her collaborators are working on. And again, Rachel is on the faculty at the University of Kentucky, assistant professor in the Department of Health Management and Policy at the UK College of Public Health. So just a quick note about logistics for today. I'm going to turn it over to Rachel. So she's going to take us through her research. Toward the latter part of the hour today, we will have time for taking questions from the audience. So we encourage you to be thinking about questions that you might want to ask Rachel as she goes along. So we have a number of participants here. Everyone is muted. So the way you ask your question is to use the Q&A box that you should see at the bottom center of your screen. Type on that Q&A box. You can type your question in at any time, and you don't have to wait to the end of the webinar, and we'll get to as many of those questions as we can. Also of note, we do record all of our research in progress webinars, and we'll post a recording of this webinar along with the slide set up on the Systems for Action website soon after today's session. So if you or you have colleagues who aren't with us today but might want to tune in at a later date, you can definitely do that. So with that, I'm going to turn it over to Dr. Hogg-Graham.
Great. Thank you so much, Glenn. I'm really excited to be here today on the Systems for Action webinar. Like Glenn mentioned, have been working with the Systems for Action team and others for a long time, and I've put together a presentation that kind of melds together a few different things that we've been working on, and going to try and go through these slides and allow us ample time for conversation. I'm really excited to just get some initial feedback from participants and ask questions and ideas. I did already tell Glenn there's some weird glitchy stuff going on with UK's internet today. So if at some point my audio goes out, I have troubleshooted how to fix it, so he can flag me down and let me know. So today I'm going to talk to you all some about work we're doing using some of the Systems for Action data, looking really at insurer contributions to population health systems and what that's looked like, and then also how that might be related to some diabetes specific health outcomes. So before we get started, I want to acknowledge funding both from, like Glenn mentioned, the Robert Wood Johnson Foundation and the Agency for Healthcare Research and Quality. They have helped fund and make this work happen. And then also some of my collaborators, as Glenn mentioned, intramural Systems for Action research team, but then also some folks here at UK that are part of this work. Doctors Beth Lacey, Josh Bush, and Teresa Waters, and Manny Nicolau, who's one of our PhD students in health services research here. And of course, findings and conclusions are my own and do not necessarily represent views of ARC and Robert Wood Johnson Foundation. So just to start a little bit about, how we got into this space and how we started thinking about, insurers as one of the sectors we were particularly interested in looking at. So as Glenn mentioned, and if you're not new to these webinars, we know addressing population health requires a multi-sector approach, right? These are community health issues and outcomes and challenges related to equity that one sector is not going to be able to do alone. Often it means bringing together folks from different sectors, bringing together resources, and bringing together thoughts and ideas to really work to improve population health in communities. So if you've been to some of these, webinars before, we know there's a great body of both intramural and extramurally funded Systems for Action work looking at these different sectors. I think there's been some recent webinars looking at food security and the role food security nonprofits play, the justice system, how they're interacting with other sectors. Myself and others have really looked at hospitals and what they're doing in these systems. And as I was kind of thinking about moving some of this work forward, one sector that popped out to me is one that we haven't, looked at a ton, both with intramural data and some extramurals, insurers. Insurers are a piece of this system. Traditionally, yes, they were providing insurance for folks, making sure they got healthcare services covered and paid for, but we've really seen that change and shift in recent years. So, very similar to some of these other more private, clinically oriented sectors, we know that payers are thinking differently about health. And this comes from a number of different reasons. The recent push toward really understanding that social and environmental factors influence health outcomes, that it's not necessarily that clinical care that someone receives, but these other more mid and upstream factors that impact outcomes. And this push has really helped payers and other providers start to think about health in different ways, right? It's more than just that secondary or tertiary care, that there are these primary prevention pieces that they should be thinking about. And, part of it is for insurers, there are potential financial gains when they participate in population health initiatives, right? So if their enrollees aren't getting certain clinical care, that's going to save them money in the long run. Perhaps those visits can be prevented by helping to connect them to social needs services or create just a healthier public health ecosystem in general. So, some of these system-wide factors that are probably driving this change, right? We've seen a lot of this happen since passing of the Affordable Care Act, Medicaid expansion and some of these pieces. So a lot of people are now on insurance that were not previously uninsured. Insured rates have really gone up, although we see that, changing some. And you have individuals accessing care that likely have greater unmet medical and social needs for this reason. They haven't had clinical care in certain elements for a long time, and they likely may be low income, some of these other pieces that then exacerbate unmet social need as well. And then just broadly, like I mentioned, the insurers recognizing the importance of population health and social determinants of health, right? To move the needle, we have to think about health in different ways. So we hypothesize that's likely resulted in insurers reallocating resources in some ways, thinking more about how they can invest in population health initiatives, infusing in those population health capabilities. And then also it's increased engagement between insurers and other sectors, that they're connecting with individuals from nonprofits, social services, other providers, local public health in the community in more and other ways than they previously have. So just some questions of interest that have really driven this research is, how are insurers engaging in population health activities at the community level? What does that look like? How has that changed over time? What are some potential factors that might be influencing that? And what's the relationship between insurer participation and diabetes-related preventable hospitalizations? So you might be asking, why diabetes-related preventable hospitalizations? And I'm going to get there in just a couple slides, why we focused in on these outcomes in particular. So a little bit about our data used. So we use the National Longitudinal Survey of Public Health Systems. This is something that Glenn and the intramural team at Systems for Action have collected for many years now. It follows a cohort of 360 communities of at least 100,000 residents. It started in 1998, was again collected in 2006, 12. In 14, Glenn and his team actually expanded that sample to now include smaller jurisdictions, and it's been collected every 2 years since 14. For the purpose of this study, we'll be using data through 2018. So as I said, I'm going to mention a little bit about analysis here, but I think if you go back in that, as Glenn mentioned, the recordings of the Systems for Action webinars earlier this fall, Glenn talked about the analysis data in really nice depth with a webinar he did looking at physician contributions. So you can go both there and to the Systems for Action website and get really great information on analysis. I'm going to give you all just the tidbits to have the context for what the study looks like. So what is in analysis? It looks at a number of different measures in terms of population health capabilities in the community. They ask local public health officials to report on the availability of 20 recommended core public health activities. We'll talk a little bit about those in the next slide. They also ask which organizations in the community are contributing to those activities. So that's where we really are able to look at the different sectors that are engaging in these population health networks. They ask how much of that effort is contributed by your local governmental public health agency or local public health department, and also gets at quality by asking about perceived effectiveness of each activity. So just a little bit about the activities. I know there is a lot on here, and we'll go through some of these with the results, but the 20 activities do align with the 3 core functions of public health. These were developed through consensus panels looking at what are core capabilities you want delivered in a community to improve population health. They fall into the assessment, policy and planning, and assurance and evaluation categories. So we'll highlight some of these in particular with the findings, but it's things like looking at health needs in a community. What are some of the behavioral risk factors? really thinking about in policy and planning that prioritizing community health needs, assessments, putting together a plan, allocating resources, and in assurance and evaluation, they're really making sure legally mandated activities are implemented and that you're monitoring and evaluating public health programs in the community. So again, you can go to some of the systems for action and see these really in detail. But a nice breadth of activities that are related to community health in the analysis survey. So like I mentioned, we use analysis data up through 2018. We also used 2012. So that's 2012, 06, 14, 16, and 18. So we did link that with some other data sources. So we linked it with the healthcare cost and utilization project state inpatient databases. So what is this? This is really our census data on inpatient hospitalizations across the US. Does not include all states, but includes a good swath of them. For the purpose of our analyses, we linked analysis data to just 16 and 18 data from HCUP. Our motivation here is that wonderful ICD-9 to 10 switch. So changed how they measure preventable hospitalizations, particularly the diabetes related ones. And it's good because they really picked up some additional conditions and things, but really challenging for folks, you know, in particular, looking at change over time. They switched in the last quarter of 2015. So a lot of that data doesn't necessarily compare. And we've tested out some different methodologies to maybe help us get more full panel, but going along with the literature, we tend to just pick up in 2016 with ICD-10 and move forward from there. So we also link to the area health resource file to control for community and delivery system characteristics, right? Just looking at what are some of those socioeconomic, demographic, and healthcare system supply characteristics in a community. So we ended up across those 2 years with a final sample of 586 local public health jurisdictions across 20 states. So we did look at this subset of jurisdictions and found that they are comparable to the larger analysis sample. There were not significant differences, and we do have pretty good geographic variety in those 20 states. But as I mentioned, you know, this is just a start, and we're hoping in the long term to really be able to acquire more HCUP data and expand this sample to get more breadth than what we're looking at. So our key explanatory variables, those insurer contributions to population health that come from analysis, we look at a number of different dimensions. So one, just any activity. Are insurers doing anything in these communities? Yes, no. We look at that total contributions. So for the purpose of looking at the sector contributions, we actually only look at 19 activities. We can't really look at if somebody helped a community fail to implement a legally mandated activity. So that pops out. So we look at the total of those 19 activities an insured is doing. And because you can get to that total many different ways, we also look at them based on those 3 functions of public health. So in that assessment, assurance, and policy, you know, of those activities, what portion are insurers participating in? We also looked at insurer connectivity and population health networks. And how do we measure this? We drew from social network analysis and looked at insurer betweenness centrality. So betweenness centrality tells us how frequently insurers are helping to connect others into the network. So maintaining strong connectivity with other sectors than those sectors have directly with each other. And in network analytics, we think about this measure sometimes as a bridging capacity, right? They're helping to bridge folks into a network that may not be activating themselves. And we thought this is particularly important, especially when you're thinking about connecting folks to services and strengthening the capacity of the network. So we pulled that into the study as well. So our key dependent variables. So we looked at 5 different dependent variables, ran models for each of these. So we looked at diabetes short-term complications, hospitalizations from this. These are just emergencies from your imbalance of glucose and insulin, right? Maybe poorly managed medications, a person ends up in the hospital for that. We looked at long-term complications. So these are being hospitalized from more sustained poor control of diabetes. So we looked at uncontrolled diabetes, so just high blood sugar levels that you can't get down. And then lower extremity amputation in diabetic patients. I think that one's pretty self-explanatory. That is absolutely a long-term complication that you hope very few individuals have to experience. Then also a composite measure that just pulls together each of those 4 individual diabetes-related preventable hospitalizations. So a little bit more on why diabetes preventable hospitalizations and what these are. So preventable hospitalizations in general are a set of acute and chronic conditions for which access to strong outpatient care can prevent or significantly reduce the chance of hospitalization. So these have a long history in health and healthcare research. They've been used to really signal if your healthcare system back in your home community is working well. A lot of quality improvement pieces related to these. Most research has looked at things like primary care. If you have strong access to primary care back in your home community, your home county, you should not be admitted to the hospital for these, or should be admitted at a low rate. But we know that very little is actually understood about these hospitalizations and other community supports. And one of the big overarching hypotheses we've had with my Career Development Award and other work, as Glenn mentioned, is that these preventable hospitalizations might actually be particularly sensitive to population health systems, integration across sectors, in addition to primary care clinical services. And so you can see over here on the right, our idea is that having greater connectivity across that population health network is, one, going to improve likelihood that a patient is connected to other community supports, right? If they present in a clinic or in a hospital or with their insurer and they screen them and find that they have other unmet social needs, having strong multi-sector connections may help facilitate connecting them to those other community supports that can address those needs. It also, in general, right, if you think about one, that's kind of those midstream unmet needs, having greater connectivity can strengthen the population health system in general, right? These very broad capabilities, resources across the community to ensure that you have a strong population health safety net. And by then, it's going to reduce unmet social needs and preventable hospitalizations, potentially keep these folks out of the hospital in the long run. So why diabetes, right? There's other preventable hospitalizations. I think most folks know this. Diabetes is costly to patients and providers. Over 10% of the US population has diabetes. Research has also shown us that there is a high prevalence of unmet social needs in diabetic patients, right? They're very sensitive to food insecurity, homelessness, the home, financial challenges related to getting their insulin and medications. I don't know about where you are, but in Kentucky, I feel like we constantly see signs up that are like, call here to get cheap insulin and medications. This may be a set of conditions in their enrollees that insurers are particularly interested in adopting population health approaches to help offset some of the financial risk related to having diabetic enrollees in their population. So we thought this is a great place to maybe start to look at these outcomes and try to understand what's going on, both that there's, very sensitive, very prevalent and very sensitive to unmet social needs as well. So a little bit about our modeling strategy. So we did use 2016 and 2018 data. So we are looking at systems over time. So we used generalized linear models with a longitudinal specification to help control for looking at the same public health jurisdictions over time. And as I mentioned, we also controlled for just other community socioeconomic and demographic characteristics, right? We know these influence the outcomes as well, especially the supply of primary care physicians in a community in some of these pieces. So we wanted to make sure we included those in our models as well. So what does it look like, right? I wanted to start just by showing you all what insurer contributions have looked like over time and some of the changes there. So here you can see just the portion of communities that report insurers contributing to any population health activity. You can see that that's gone up over time. And in particular, between 2014 and 2018, we've seen that slope really increase. So really going from about a little over 50% of communities reporting insurer contributions to 60% in 2018. In terms of connectivity, right here, you're looking at degree centrality, which just means the number of those population health capabilities insurers are contributing to. And then also between this centrality, as I mentioned, that connectivity piece. Again, right, we see it going up over time, which is a good thing. But in particular, between 16 and 18, we see those slopes get steeper and more happening in between those 2 years, which is nice, especially given some of the data that we have from HCUP. So if you look here, this is looking at those population health activities analysis, and we've got all activities and then bumped out by the assessment, policy planning, and assurance and evaluation. One thing I want to point out here is you see that there is room for improvement in general for insurers. So they are one of the sectors we see participating in population health capabilities at pretty low rates. So you can see here that over time, they have definitely done more in policy and planning activities, which makes a lot of sense. And, that's increased to in 2018, they're participating on average in communities in almost 20% of those policy and planning activities. At much lower rates, assurance and evaluation. And we'll talk a little bit more about that related to some of our findings as well. And in assessment, although we've seen some pretty decent gains in assessment from 2012 to 2018. So it's kind of interesting to see these buckets and where insurers might be participating in specific activities. So looking at those, I know it's hard to remember what was an assessment, what was in other those. I just wanted to call out some of them and pull them up so that you all could see some of the specific results and areas where we've seen some interesting changes over time. Across the board, you can see, when you look at percent change, it's pretty substantial, but in part that's because you're looking at pretty low values in some places, right? Like conduct laboratory testing. And then maybe you don't actually want an insurer doing that a lot. That is someone else in the public health system's role. But interesting places where we've seen a lot of change. Conduct periodic assessment of community health status and needs. That has gone from almost 15% in 2012 to 28% of communities reporting that insurers are engaging in this activity. Kind of similar with the analyzed data on community health status and health determinants. We've seen a pretty substantial change there as well, perhaps signaling that insurers are starting to engage in activities, thinking about the communities that their enrollees live in and what those communities' health status looks like. So policy and planning, we have more in this category. Just to kind of call out again, some interesting ones. We see some pretty substantial changes and high rates of participation in the prioritizing of community health needs, engaging community stakeholders in health improvement planning, and develop a community-wide health improvement plan. This is good, perhaps showing that insurers are engaging in these different pieces. Again, unfortunately, as you look at some of these, still pretty low rates. And part of that is likely when you think about an insurer, right? Their population is generally a pretty wide swath of folks. So how do they really think about how they prioritize their efforts? And I will say, we're just looking at average tendencies right here, right? Like when you think about variation, there are some communities where insurers are doing nothing, and then other communities where insurers are doing 100% of things. So this is just giving us a nice initial overview. But again, another place, even though it's a pretty low percentage in general, but where we saw a substantial increase was the allocating resources based on the community health plan. We went from 5% communities reporting insurers doing this in 12 all the way up to 11.6% in 2018. And then the last is assurance and evaluation. Keep this one in your minds because we're going to come back to this. But again, we see insurers doing, pretty low rates of this, with the exception of linking people to needed health and social services. They participate in this at a pretty high rate comparatively to what else they're doing. That's a good thing, given some of the changes we've seen in how private sectors are addressing health. So just a little bit on the longitudinal trends in diabetes-related hospitalizations between 16 and 18. So they are going up. And what you're looking at here is, I did want to compare what we have in analysis to national data on preventable hospitalizations. And you can see for the most part, it's pretty close. In some cases, there's small variation in what our sample looks like. Again, we're hoping eventually to pull in more data and perhaps may bring those lines back together in some situations. And particularly if you're looking at long-term complications, analysis rates that are in our sample are a little lower than national averages. Same with lower extremity amputation. But you can see that between 16 and 18, we have seen diabetes hospitalizations go up. What's interesting in some of our other work, we've looked more broadly at all preventable hospitalizations, and we actually see some of the others are either staying stable or going down. So we see a differential trend, especially in those diabetes metrics. What did we find when we put our models together? So this is where things get kind of interesting. We found that there was variation dependent upon how you looked at insurer participation in these networks. So we found that with insurer between the centrality, right, that helping to connect, gatekeeping, that diabetes, long-term complications, uncontrolled diabetes, and lower extremity amputation rates were significantly lower in these communities. Not surprisingly, you also see that with the composite when you pull that together. When we looked at if insurers were doing anything in the community, so yes, no, 0, nothing, or 1, they're doing something, we found that diabetes, long-term complications, and lower extremity amputation rates were lower in these communities. When we looked at total contributions, we found nothing. And part of the reason I think is because when like I mentioned, there's a lot of different ways to look at total. So to help address that, we looked at the bucket out of those 3 different functions in the analysis activities. And this is where things get a little bit interesting. So consistent with our previous models, we found that diabetes long-term complications, right? That's the one that tends to pop up the most. It is the highest of the diabetes individual PQIs across communities. We see a high rate of this. Associated with policy and planning and assessment activities, lower extremity amputation also associated with assessment activities. Again, the composite pops up there, right? Because that's made up of those, largely made up of long-term complications. And boy, was I surprised when I saw the assurance and evaluation results. And there we actually see a positive association. So the more an insurer is doing an assurance and evaluation activities, you have higher diabetes long-term complications rates. And so why? I think there's some reasons for this. We are only looking at 2 years of data, and we aren't kind of trying to figure out what comes first. Higher rates of diabetes, preventable hospitalizations, and more insurer contributions, or vice versa. And when I started thinking about these and kind of going back to look at, I'm going to click back to these activities. If you think about assurance and evaluation activities, yes, they are absolutely necessary in a strong population health system, but really with the exception of potentially linking people to needed health and social services, maybe you don't want an insurer doing a lot of these, right? You don't necessarily want them evaluating the local health department, capacity and performance, looking at health programs and services. Perhaps it's that there are challenges in these systems. They already have really high rates of these preventable hospitalizations and other poor health outcomes. And that's what we're seeing the insurers step in on. We absolutely want to dive into this further. And one way to do it is to kind of think about pulling in and modeling some of these individual activities, which would be particularly interesting in the other places as well, right? We see some positive association or negative associations in the policy and planning categories. Again, looking at community health status, helping to develop a plan and allocate resources. That may be part of what is happening there. Same in assessment, right? What exactly are the activities that may be driving lower rates of diabetes-related preventable hospitalization? So we're hoping to move forward with some modeling where we look specifically at this. One of our challenges is by their nature, a lot of these activities are collinear. They group into these functions. So really thinking about how we can further tease that out with also understanding, not one size fits all. What works in one community might work in another. So really digging into look at, what's going on more granularly with some of this, but, promising to see that at least initially using a couple years of data that Insurer contributions to these population health systems, there are some at least preliminary associations with improved health outcomes, especially around these diabetes related preventable hospitalizations. So, we don't see anything pop up with short-term complications. And my colleague, Beth Lacey, who cannot be with us today, but is absolutely our diabetes expert, her and I talked through this and realized, those short-term complications, that's often you don't have your medication. You can't control, these are emergency events. And so we might not pick up a signal there, and that it's more this long-term addressing, unmet social needs, either through direct referral of patients or helping to improve that system, back in their community. Same with lower extremity amputation. You don't want that to happen. That's a long-term outcome, especially education, and some of those factors can really help improve that. So uncontrolled diabetes is really similar to short-term complications, and those kind of tend to run together. And often when they tell folks how to look at these, how to think about quality improvement, to really think about those two measures together. So let me click on through just, some of our initial conclusions. We know that insurer participation in these population health networks has increased over time, and they're playing more central roles in the delivery of these population health activities and functioning as a bridging organization, right? They're helping to perhaps engage folks into these networks. We see that insurer participation is associated with lower diabetes preventable hospitalization rates, but with variation in measures, both the diabetes outcomes and how we're looking at insurer participation in these networks. And of course, assurance and evaluation activities are associated with higher rates in the composite and long-term complications. Just a couple implications for policy and practice, just kind of thinking about insurer participation in the delivery of these activities. It does have the potential to help improve diabetes related health outcomes. So, there is at least an initial signal showing us that something is going on there. So really thinking about both policies and, practices that help expand insurer coverage, that's going to help shift insurer orientation, right? So thinking about Medicaid expansion, a lot of states that haven't expanded, they are in the diabetes belt. So what potential gains, could happen there? How do we get insurers to continue to keep that population health orientation, even with some changes that are happening in the insurer market? So some of the limitations and next steps, as I mentioned, as we were going through, we're limited to those networks that we can link to HCUP, right? HCUP is not national. It's not across all states. We are actively working to get more data, purchase more, starting to purchase 2020 data because there is a lag there to really get a much broader sample, which will help us do more analytically. In analysis, we are looking at insurance participation in these networks very broadly, right? This is a large national survey. Local public health officials perhaps have limited time to fill it out. We're getting a broad swath of what's happening, not a lot of depth to really fully understand what are some of the mechanisms in these networks, what's really going on in these partnerships, what's really going on in the provision of these activities. We aren't measuring the quality of that interaction, right? Again, it's just yes, no. We aren't asking about, what types of activities do you trust, do you value? What do these relationships look like in operation? The data is coming from the local public health perspective, but if you go back to that webinar of Glenn's that I mentioned, he talks a lot about some of the initial validity and reliability work that their team did when they started analysis. Local public health officials tend to have a pretty good view of what's going on in the community, but if anything, we're likely perhaps under reporting some of the activities that are going on. One thing, and we really are actively working on, is merging with additional data on the market. So we're just looking at insurer broadly. We're not thinking about Medicaid, Medicare, privately insured. Is there variation based on these different types of insurers in terms of what they're doing. I'll give you a preview and say yes, and I'm going to talk a little bit about that. And then doing some additional mixed methods work to really further understand insurer roles. So I know we're about at time and I want to leave plenty of time for questions, but I wanted to pull in, as Glenn mentioned, our team here at UK has been funded through Robert Wood Johnson through a different mechanism, the Research and Transforming Health Systems. And so that project looked specifically at Medicaid managed care here in Kentucky. We have a very robust Medicaid managed care market, 6 MCOs, and how they are partnering with community organizations to address unmet social needs. So my hope is, as we continue to expand this area of research, being able to combine what we find in analysis, that really broad perspective, with what we see in kind of more in depth in these communities. So I wanted to share just a little bit from that project. We've just recently wrapped it. So these are hot and emerging findings. And so we're hoping to kind of push out more from this. So as I mentioned, it was looking really specifically at Kentucky. I mean, the nice thing about Kentucky is you hear a lot about Appalachia, our rural areas. We have those, but we also have some urban areas in the state as well. With this project, we really dug in on what MCOs were doing from a number of different ways. We did a lot of qualitative interviewing, both with MCOs and the community partners across the state, to really understand how they're thinking about unmet social need, how they're connecting with their community partners. We then did some network analysis using the partner tool, which was developed by Danielle Varda, a longtime collaborator of ours and funded by the Systems for Action group as well, to really understand what those networks look like. And so very preliminary evidence. I can tell you all this is a network in the eastern part of the state. So we had a very active study advisory board with this project. Lynn was actually a part of that. And we had representatives from all of the MCOs. We had voices from Medicaid enrollees, and then also community-based partners. And we dug in with them and we picked 6 geographic areas in the state to really understand what MCO community partnerships looked like. Some of them were single counties, the more urban areas, and others we grouped counties together. This is a grouping of counties in eastern Kentucky. So what you're looking at here is the different types of organizations. I'll just draw your attention to the hot pink are the MCOs. And what we can see here, just looking at the whole network, is you really have a pretty centralized structure in this network. You've got the MCOs, but then that bright red dot is a local public health agency in eastern Kentucky, doing a lot in the screening and connecting of Medicaid enrollees to community services. Outside of that central node, you really kind of see effort is pretty evenly distributed with the other organizations in the network. It was really low density. So of those partnerships that could be in place, we saw only 7% were actually in place across these organizations. And, most importantly is we found that the majority of partners were nonprofit organizations. And we're hoping to code this data a little more granularly to find out what are those, are they food security, legal services, homelessness, what role are they playing in the communities? And while we found in this particular communities that MCOs absolutely were playing an important role, and again, I could do a whole webinar just on this project, local public health and community nonprofits are also really playing central roles in these activities. So these are the kinds of questions and research we're hoping to do moving forward to really kind of triangulate some of our different findings. And just quickly, the cool thing about partner and what Danielle has developed is you can really look at what, but also, certain aspects of what and the quality of those relationships. And so when we asked how frequently organizations were referring enrollees for unmet social need between each other, we found, some pretty interesting interactions that when you ask daily, not a lot happening, more happening between local health departments in those communities, nonprofits. You see one MCO kind of popping in. You see those networks really coming together when you look at more of a weekly and monthly basis. So again, ask some interesting questions about what exactly is happening with those referrals, who's playing the roles in connecting enrollees across those, and what does that look like in practice? And we've got some qualitative data that soon we're going to start analyzing to really help look at that and kind of triangulate some of our network findings here. We did ask about partnership outcomes, right? So some of those mechanisms that I mentioned, like what exactly is happening in these networks when we see specifically MCOs engaging in unmet social needs screening and referral and partnerships. And, you know, you can look at the arrows and see who reported what, but, you know, kind of interesting when you look at improved services and community capacity to address unmet needs, you know, a lot happening there. Less with, you know, some of the MCOs are helping to do that, but more really with that larger constellation of community partners, you know, the health department. Actually know that health department director, and they're someone who very much is public health 3.0, but you can also look here, I pulled the led to an exchange of resources and new funding opportunities. And you do see MCOs helped with that in some capacity. So again, partner is a really great way to kind of dive in on what exactly is happening in these communities and these networks. And then last, it also asks about trust and value. So Danielle has created these awesome scales, because if you were to send a survey and say, hey, do you trust, you know, X organization, folks might not be super honest about that, but to get at trust and value, asking about things like power and level of involvement, supportive mission, discussion. And what you just see here is comparing the MCOs to the whole network. And, you know, on average, especially in the value, they rate a little lower, with the exception of power influence, which is not surprising. We tend to consider a 3 to be a good score here. So it's a fairly healthy network, but definitely some room for improvement. You know, they see that MCOs are open to discussion and in support of the mission, but perhaps they could do more with resource contribution. So that's just a little sample. Like I mentioned, a lot more data from this project to share, and findings coming from it, really kind of using that in tandem with what we're doing with the Systems for Action intramural team to really figure out and dive in on what's happening related to insurers and population health activities in these systems. So I will stop there to answer any questions that folks have.
Fantastic, Rachel. Thank you so much. Really, really interesting work coming out of your team. And so we're open for questions. So again, feel free to use the Q&A box down at the lower center of your screen to type in your questions. We've got several already. So let's jump right in. First question, is an increased contribution to assessment activities among insurers partly due to consolidation of payer and nonprofit hospital systems? What are your thoughts about that?
I would say that absolutely could be part of what's driving that. And that's where I think we really want to dive into some of those market characteristics. You know, we're trying to think through how we pull together those different data sources and what that looks like. You know, we found, like, for example, Kentucky has some great data on what their markets look like. It looks like we're potentially going to have to purchase some things to really look at that much more robustly, but I could see that that's absolutely what's happening there. And perhaps it's that, you know, conflating of categories and some other, which is what's great about analysis, to give you that initial look and then dive in and really figure out. Glenn and I did a Kentucky specific analysis looking at some of those analysis categories, and found that universities was really popping up as a strong driver of lower preventable hospitalization rates. And we realized that is probably extension in our state, because every one of our counties has an extension office. Every one of them has a UK piece. So I think really teasing out what exactly is happening there, especially with those mergers, you know, could potentially be explaining that. Absolutely. So we're hoping to pull those data sources together to explore that more.
Fantastic. And I do think insurers, you know, have been getting more savvy about how to use their the data systems they're sitting on top of, which we're learning more and more about, you know, how those, you know, claims data and increasingly electronic clinical data that insurers are amassing can be really powerful tools for public health assessments. So fantastic. Next question. Have you looked at what insurers are reimbursing on for population health screenings through value-based versus fee-for-service contracts with providers?
I feel like whoever asked this question was sitting in a meeting with our research team that happened last week. So this is something, we've got a lot of this in the qualitative data. So we asked some really specific questions about how the funding for this happens and what it looks like. And, what are they reimbursing for? What can they reimburse for? What have they used other mechanisms to do? And it's really interesting. Just kind of preliminarily, we haven't analyzed this piece specifically in the qualitative data, but they're doing lots of different things. Some of them are setting up really specific reimbursement mechanisms. Others are just throwing money at a community around an issue. So stay tuned. We did ask about that because we were particularly interested in what that looks like, especially thinking about how you improve capacity in some of these community organizations. We know challenges around not being able to reimburse for some of these services has been part of the problem. So we did, in the second Robert Wood Johnson study, kind of really dig in on some of those questions about what it looked like, at least specifically in Kentucky. I can say a lot of our MCOs are national in how they operate as well. So we're hoping to really push some papers out and pull that data out.
Fantastic. Another question, given the association of increased prevalence of diabetes with older age, have you considered looking at Medicare Advantage market characteristics as a variable in your analysis there?
Absolutely. So just kind of related to being able to pull in some of those market characteristics, right? We know preventable hospitalizations in general tend to be higher in older folks, not surprisingly. Our hope is to get access to some of those market variables, pull them down. We also want to move forward with some studies digging really in on the aging population, right? We know they have pretty complex health and social needs. So what does it look like specifically for Medicare patients? And I think our team would like to maybe potentially replicate some of what we've done looking specifically at Medicaid patients to understand what's happening with Medicare. We did find in a study that Glenn and I currently have and some others under review that there is some interesting variation when you do bump out by payer. So we can at least do that in our Kentucky HCUP data that we have that we left at the patient level, that you do see differential associations based on which sectors that you're looking at. So I think, again, looking at it broadly, Insurer is great for a first swath, but it's really important to pull in some of these other characteristics. It's just, as probably a lot of folks on the call know, pulling together all those different data sources and which ones are publicly available and which ones are not, so that we can really look at and answer some of these more market related questions.
Fantastic. And as one specific example of that Medicare Advantage effect, some of you, we did a webinar earlier in the last year on some work we've done with Humana Health Plan around evaluating their Bold Goal initiative, also using the same data source Rachel's talking about. And that I think Humana's whole population health initiative and Bold Goal is an example of the Medicare market incentives leading a private plan like Humana to really begin to invest in population health, because there are pretty clear market incentives for doing that for Humana. And you go back to that webinar and hear from Humana, they're pretty clear about why they're investing in these activities. It's not just a philanthropic activity, but there's actual business reasons to do that for them. So fantastic. And that's work we've also did with our colleagues at University of Kentucky. Next question. Are you seeing any additional investments by MCOs in these community networks that they are referring into?
Yeah, so kind of related to the question about how they're reimbursing, stay tuned. We asked, really specific questions about how they're investing and what that looks like. And like I said, it's a wide variety and how they decide to think about these pieces. So we have a pretty active MCO Health Insurers Association in the state. So they did things like really focus on counties with low vaccination rates and come together to invest in some of those pieces. We do see a lot, and I think to the person that asked, because of the reimbursement challenges, a lot of what they're doing is funneling money into these communities. just to kind of, here you can have this. And I think we actually have a paper that hopefully will be out in the American Journal of Managed Care soon, looking really specifically at COVID and these relationships. And there they talked a lot about how COVID kind of gave them some flexibility to just give dollars, right? If a community organization came to them and said, we need help, they were able to do that. But, thinking more collectively about what they've done pretty broadly and investing in data, a lot of these screening and referral tools, I don't know if Danielle or any of our other colleagues happen to be on this call, but we find that that's a mixed bag, right? Hopefully we have some results coming out related specifically to data and technology, that there's substantial investment happening in these tools and gathering resources. It's really heavy on community organization capacity, though, to ask them to use those. So we do see some investments in places. There are certain communities, if they see a lot of food security, they make sure in Kentucky, that's a lot of churches that are running food banks and things like that, that they are investing strategically in some of those pieces, but there's variety, right? Strategic investment and just a lot of here's $5,000, have at it. So.
Fantastic. Another question, can you share your sources for your measures of trust and value perceptions you mentioned?
Yes, so that is from, like I mentioned, the partner tool. Danielle Varda developed those. They're actually integrated in that tool. I think, let me see if I will stop share and see if I can link that out in the chat for you all.
Fantastic. We've got a couple of other questions to see if we can get to while Rachel multitasks here. So what's the strongest determinant of insurers choosing to participate in public health activities? Do you have an opinion on whether policy should mandate insurer participation in population health? Great question.
This is a really good question. So I think from what we've seen, especially with our Robert Wood Johnson project, and combining that with what we see in analysis, I'm going to attempt to, I am a mom, so I'm pretty good at multitasking. I'm going to log in and pull a partner for you all and answer this. I think, especially when we saw what freedom MCOs were allowed to have with COVID, right? There was just a lot more they can do, and they did it. A lot of them expressed concern that was going to change, as we came out of some of the flexibility that was given there. I think in some ways there is going to have to be policy mandate to keep it sustainable, right? Because you're going to have to keep MCOs focused on it very thoughtfully. But I think you're going to need those policy pieces to also help infuse the community-based organizations, because MCOs are trying with some of these pieces, but until we make it very sustainable, right? And that's the whole argument with some of this, social needs screening and referral, as Glenn mentioned. We've had other projects looking at this, is it needs to happen. It should happen. But a lot of the effort ends up being put on community organizations. And what we found, as we started interviewing, one thing that was just really interesting for our team to find is we had planned on doing a second set of qualitative interviews where we talked to folks that were on the ground at both MCOs and community organizations. And there's definitely that structure in the MCOs, right? You have the more administrative C-suite roles, and then the folks that are doing everyday screening and referral. That's not what life looks like at a community-based organization, right? There was no on the ground. It was everybody doing everything just to make it work. So I personally I think, and after seeing some of this research and hearing qualitatively what these folks said, you're going to have to put some policy mechanisms behind it to help make it sustainable in the long run.
Fantastic. So there's a request, Rachel, for you to come back and do a follow-up webinar on your nonprofit analysis, role of nonprofits in these networks. So we'll give you a standing invitation to come back and do that. We've got some other questions here. We'll do one more. Question about gestational diabetes. Have you thought about looking at that separate from the more general diabetes patients, and
Yeah, absolutely. So interesting. As someone is Glenn, I had gestational diabetes. So this is something I've actually thought a lot about in this research, right? Thinking about the cost of, and I know we have just one more minute. We have an application. So one thing I should mention is that second Robert Wood Johnson project was jointly funded by the State University Partnership. So we also were able to get funds from our Medicaid office here in Kentucky. We have an application under review to get us a lot of Medicaid claims data. And if we can do that, our hope is to link it to some of these networks, and that will give us a lot more flexibility in what we can look at, right? Right now, we're just using these community level preventable hospitalizations, but having that patient level claims data will give us a lot more power. So.
Fantastic. Well, I know we are out of time. This has been a wonderful session. Encourage everyone to keep an eye on Dr. Rachel Hogg-Graham and her research team. They're doing excellent work. You're going to want to continue to track this work and where it's going. We'll make sure to have her back to give us an update as this work progresses. Thanks so much. Please continue to join us at Systems for Action in our recurring webinar, Research and Progress webinar series. So long, everybody. Have a great rest of your day.
Yeah. Thanks.
Bye.